Alex, Georgia, thank you so much for joining us. It's great to have you here. Would you like to just introduce yourselves?
So I'm Alex, I'm the clinical lead OT for neuropsychiatry.
I'm Georgia, I'm a specialist occupational therapist for neuropsychiatry.
That's great, thank you. I guess for anybody listening, neuropsychiatry is a very specialist service line for occupational therapists and other clinicians that work within the field as well. Do you want to just explain a little bit more about what exactly that means and how that might look for the people within those services and for the OTs working with them?
So I guess neuropsychiatry is that link between neurology and psychiatry. So even within that, we have quite a range of patients that access neuropsychiatry. So they might be patients that have had a brain injury and that has resulted in some kind of mental health diagnosis following that, and then they need that specialist input from a neurology and neuro rehab perspective, but also need that psychiatry support. They might have had that mental health diagnosis prior to their brain injury, and therefore they still require that really close monitoring from a psychiatrist, but also then require the specialism of neuro rehab. But we also have those neurodegenerative patients come into our services as well. That can require that specialism from a neurology perspective, but also that close monitoring from a psychiatry perspective because of various mental health diagnoses that come up because of that neurodegenerative condition.
Mixed in with those physical needs as well of the neuro side.
Yeah. So with all those different threads running through it, I imagine the difficulty is keeping that up to date best practice when you're having to pull on so many different things and building those networks. You're having to have a foot in very different camps, aren't you?
There's a lot of learning curves, I think, and having to pull from lots of different resources just because of the wide range of diagnoses that we do get.
And I guess we kind of bridge that world between what would be a traditional neuro rehab route, where there's lots of guidelines, there's lots of structure around what neuro rehab looks like, but our patients don't really fit into that world. So from our perspective, we have to have that understanding, have that knowledge as to how to treat the traditional patient that would go into a neuro rehab service, but also have that understanding of the different range of mental health diagnoses that patient could present with, and have that knowledge and understanding of how that will affect their rehab, affect how we approach their treatment, and kind of have that foot into both kind of sides of it, I guess. Yeah.
So Alex, as the clinical lead for the service line, you've led on developing that model that relates specifically to the neuropsychiatry services and brings all of those things together, haven't you? Which has enabled us to standardise that across all of our services. Can you maybe explain to people how you did that and how that journey looked?
I guess it was quite a difficult task because there isn't that research that's out there to say this is how you be an OT in neuropsychiatry, which if there was, that would make life really easy. And I guess we really needed to look at the patients that we have in our services and that range of patients that we have in our services and realise that there isn't a one-size-fits-all for them. So when we came to kind of making a model, it wasn't this is how you treat a patient that comes into our service, because every patient is so vastly different from the next one. And we really needed to make sure that we had a range of resources that all of the OTs in the service could use, but to make sure that it's really patient-centred. And I think that's really the key for developing the pathway and the model of occupational therapy within neuropsychiatry, that it's absolutely led by the patient's needs, what their strengths are, what their difficulties are, and what their goals are. But just making sure that we also then had this range of resources around that model that we could pull on, as depending on what the outcome of our assessments were or what a patient's goal was, and that we had all of those resources.
So the thing that's really obvious is how vastly different each individual is that's coming into those services, which makes this a little bit tricky, I suppose. But for anyone listening who can't maybe picture what life's like within those services, what's or one of the usual or typical kind of pathways for a patient coming through? What kind of goals would you be working towards, and what would be the next step for some of those individuals?
Again, like Alex has said, it's also varying. I think one of the phrases that I like to use is treat the patient, not the diagnosis. But it would typically look with, initial assessments, information gathering via family and things like that. But goals are so varied. It could be around their physical needs, to improve their walking or their exercise tolerance. But then it could also be around looking at those coping skills with their anxiety levels or accessing the community in a graded way. And then also down to that emotional regulation as well, how to manage their emotions better in different environments and challenging situations.
And I guess that's what is the fun bit about neuropsychiatry, is that we don't ever have a typical day.
No.
We could be working on a goal with a patient that's them being able to brush their teeth, and we're practicing their pulling movements and their grasp and release to be able to brush their teeth, and that's their goal because they can't do any of the other parts of their personal care independently. And then the next session we're going out on a bus with somebody to go and look at some voluntary work. And so that's the kind of vast difference of the patients within the services, but that's what I think keeps us on our toes and keeps us so engaged in the service and makes it so interesting.
I think that's really helpful for people just to get a bit of an idea of what some of those things might be. And like you say, every day is completely different, isn't it? I know we've kind of touched on the book a little bit, and we don't want to sort of share out today everything that's in there, so there's nothing left for people to read, but you have included a case study in there, haven't you? And I wonder if you could just touch on that a little bit and give people an idea of what to expect within that case study.
So the case study is one of our patients that we've got in our service at the moment, and he came to us from another hospital. He'd got a long history of various mental health difficulties, had taken an overdose of an illegal substance, resulted in his brain injury, gone into a hospital. So we're then having contact with that patient 10 years post brain injury, which can be quite typical for some of our patients that are coming in.
Sorry, don't mean to interrupt, but for anyone listening who maybe isn't familiar of working within those brain injury services, that long wait, what are the implications of that?
So I guess from our perspective, we want to have a patient as soon after their brain injury as possible, because we would expect somebody to make the most progress in the first 18 months, 2 years post their brain injury. And for us, that's when we see the most progress that happens. When we receive somebody into our service that their injury has been 5 years, 10 years, 20 years, then we're really looking at that patient from a very different perspective. We look at that rehab model. We try and look at their ability to learn, how they respond to the rehabilitation. But then we also need to think about, do we need to look at a different method of treatment? Do we look at a more compensatory strategy? And that might be very typical for those patients that are 10, 15, 20 years post brain injury, but they very much still then need that neuro-rehab service, because the difficulties they're presenting with are because of their cognitive impairments or their physical impairments. And we'll quite often have patients that have come to us from a psychiatry service, but where they haven't had that understanding of their brain injury and the impairments because of their brain injury. So they come into our service, and because we understand that, and we do those assessments that are in more depth, then we can identify the right support.
Yeah, get those management plans in place that are just that little bit more structured and focused around that neuropsych method.
Yeah.
So that's that real risk, isn't it, of sort of working purely from one perspective and not having a team around the individual who understand all those different parts, you're certainly not going to get that same outcome, are you, with an approach that looks at it also separately.
And I think that one of the case studies in this book, that had been his experience. He'd been in a service where they didn't really understand how his brain injury had affected him. He didn't initiate anything, so stayed in his room and didn't want to come out of his room, so he didn't. And people just thought that, well, that's what he wanted to do, and he was,
low arousal levels or something along those lines, but...
But actually, he needed us to support him. He needed us to be going in and saying, it's time to get up and it's time to have a wash and it's breakfast in 10 minutes, and needed that prompting and that support. And that's very much what we did. There was those support plans that went in that everybody was aware of, and so that he had that structure to initiate. Yeah, and it definitely needed that consistent approach. If we were having one person going in prompting him on a Monday, it needed to happen on a Tuesday. Otherwise, he'd be out on a Monday and he'd have breakfast, but the rest of the week he'd stay in his room. So it was those kind of management plans, that structure that we provided to him. And to be able to just come out of his room, attend to his personal care and come down and have breakfast. And initially, that's what our goals were, that he was doing that on a daily basis. The fact that he now then goes out and he engages in activities and he goes out and accesses the community, and we're looking at him moving on into supported living, is an absolute bonus, because initially we were just wanted him to come out of his room.
And I think with this case study, that's what it was. It was paring it right back. To then be able to look at what goals actually could be reached in the future with that. Yeah.
Really starting at the beginning and then building that up and adding new goals as it progresses, isn't it?
And it's those short, achievable goals that could, for him, they increased his motivation and to work with us, because we showed that they could work for him.
So it's such a rewarding and complex service line, isn't it? It's certainly something that over time you start and get a lot back when you see those smaller changes. What do you think the biggest challenges are of working with that patient group?
I think one of the main ones is just because of how specialist it is. We get patients from all over the country, from up in Scotland, from Wales, and we're based in the northeast. So then trying to get those family relationships, or even gathering some of the information to support home visits or access visits, those types of things just take a lot longer sometimes, and it's harder to make those connections.
Yeah. So everything that we're wanting to do, that we do with our patients in the service, our ultimate goal is that works in the community. We never want somebody to stay in hospital. It's all, the first part is that rehab, but the last part is that discharge, that transition, that community reintegration. But if their family home is 3 hours away, then that's really difficult. And the difficulty is that there is just not enough neuropsychiatry services across the UK to be able to support the patients that would need that kind of intervention. And so that has been a big challenge, but also discharging our patients out of our service because of the level of support and the speciality that the speciality services that they might require when they leave us can be really challenging.
Because they don't almost fit the pocket of an ABI placement or a mental health placement. It's where we have to sometimes tailor make what's going to work.
Yeah, it's finding those really bespoke packages, isn't it? And making sure that they're able to sustain that level that you've achieved with them.
And, keep on those plans and management plans that we've put in place that have worked so well, so that we're not going to then have that readmission.
Yeah. And reassuring those community services, I think, what a traditional community mental health team think about the patients that are coming out into their service. You tell them they've had a brain injury and they present with all these difficulties, and actually we need to reassure them that they can manage these things because we've put this structure around, and that's what needs to be replicated. And we do a lot of that where we start to pull back a little bit to show that patient's independence, so that they can be supported and moved out into the community, because that's everybody's ultimate goal.
Absolutely. I think in any successful service, for me, one of the key components for getting that right is that multidisciplinary team working. But in neuropsychiatry especially, I think you've got such close working relationships with physio, with the speech and language therapists. Do you want to maybe talk a little bit about how that looks and about how you all work together for the best outcomes?
I think right from the beginning, we all try and take a very joint approach, especially because you'll find that there'll be so many other areas that you can pull from, and it's sometimes difficult to do your initial assessments without a speech and language therapist there to work on the communication aids that you're going to need to ensure that that patient is understanding what you're asking of them, and then you're getting accurate data from those assessments. So we definitely work very closely with the speech and language therapists throughout. Psychology throughout, I rely very heavily on their support plans around behaviours, just to make sure that we're not going to upset the patients or in any way, or how to then manage it if situations do occur. So it's definitely an area where we all work really closely together. Physiotherapy, again, we work massively closely with them just to ensure that, when we are completing those activities of daily living, we're doing it in the correct way that's going to be beneficial to their current body ailments.
And I think interdisciplinary working in neuropsychiatry is massive. We do so many of our assessments together because we might be wanting to look at very different things, but we're doing it within the same occupation. And so it doesn't make sense that I go and do something and then the physio goes and does the same thing. We do that together because we're both learning what we want to see from that assessment, and the patient is just having to do that once. And we do a lot of our work is interdisciplinary, and not just with OT, physio, SLT and neuropsychology working together. It's also the psychiatrists as well, of kind of understanding how the titration of their medication is affecting their engagement in occupation, and kind of working together as to how do we need to tweak that medication to make sure that they can engage in the rehab, because ultimately that's why they're with us for rehabilitation. And sometimes we are reliant on the psychiatrists to work their magic from a medication perspective to allow us that opportunity to be able to do it. And I think that's the beauty of neuropsychiatry, that we are able to do that with the patient in that one building without having to refer to a psychiatrist that might not see them because they've got a brain injury, and the neurorehab consultant can't prescribe antipsychotics. But actually we're looking at that patient from a holistic perspective altogether, and those conversations that we have as a team, we're all coming from a different perspective, but it's ultimately because we want the same outcome for the patient, but we're able to tweak who's having the primary input at that point. Is it we're looking at medication changes so that we can get them out of their room and initiate coming down for breakfast, or because we need them to engage in physio and we're trying to improve how much they can walk, or just to be able to transfer independently, and then we can work on a personal care aspect. So it's very much us working as a team to see who's the taking point at that point in time for that rehab.
Yeah, someone different taking the lead each time.
Yeah.
And what's advised by some of the other professionals as well. Sometimes with the speech difficulties, the patients can lack insight into their own speech difficulties. So it's important to know what the professional on that matter, how they want you to approach that situation. Do they want you to be explicit in the fact that the words coming out of the mouth are not what they think they are? Do they want you to just encourage the speech? I think that's important as well, because you don't want to take back steps. So it's definitely just picking what you need from each profession.
And I think that's when, because we work in an interdisciplinary way, if I'm doing wash and dressing practice with somebody, then we're making sure that they're standing how they're standing in physio. But I know that because we've done a joint assessment. So we might be doing wash and dressing practice, but we're also working on their standing tolerance, their technique to be able to stand, which they're doing in physio. We might be working on a communication technique that speech and language therapy are doing. We might be working on some cognitive skills as well. So everything that we're doing is bringing in the whole team into it.
Yeah. And it's that feedback loop as well, isn't it? It's that working with the nursing team, working with the support staff, the activity coordinators. When you're all one team together like that, and you've got that educational structure amongst yourselves, that you're all learning from each other all the time, it does make that much stronger throughout the whole of every day, doesn't it? Because everyone is aware of what that patient's care plan looks like, or, you know, the things that they need to be doing to contribute to that.
Yeah, and I think from in the neuropsychiatry service line, we understand and put a real emphasis onto that, particularly the support worker training. You know, we need to ensure that they understand our patients, they understand why we're asking them to do something in a particular way where it might not make sense to them, but it makes sense from a rehab perspective. And it's really important. And that is ultimately our responsibility, to ensure that they understand why we've put that support plan in place, why it's so important, why we have to go and prompt the patient to that it's time to have a wash, that breakfast is going to happen, and why that needs to happen 7 days a week, not just on one day. And to get the support workers, I think, to understand the journey that a patient has gone through and why we put the amount of effort we do into their rehabilitation, because, you know, they walk into the building, you see this person in front of you that might not be able to regulate their emotions, be highly distressed, but, you know, we do their initial assessment, we understand all of their history, and the support workers sometimes don't understand, you know, their history and how they're presenting may have started from childhood, and this is a 70-year-old man that's walking in highly distressed.
And they haven't always got the time, have they, to
No,
gather that information.
absolutely.
I think if as a team you're able to filter that and pick out the pertinent points and decide where that educational focus needs to be, it's much easier to get everyone on board, isn't it?
Those snapshots of information that then can just massively improve the care that patient's getting.
What would be the advice that you would give if anybody listening was thinking, you know, that sounds like the kind of people that I'd like to work with, you know, maybe a newly qualified OT or someone thinking about a bit of a change of direction? What advice would you give them?
I guess just throwing yourself in to it. I think sometimes people think neuro is scary. And I remember as you know, a band 6 OT on having band 5 OTs rotate onto my service in neurology. Everybody was like, I don't want to do that rotation. It's scary. The patients are difficult. But actually they come away thinking, oh my God, you know, I've had, it's so rewarding. I've made a real difference to that patient, and developed that love for neuro rehab. And I think there is that fear because they are complex. And I think it's just throwing yourself into it and learning from the people around you. You know, we all, you know, we all learn every single day. We don't know everything, and we learn from the psychologists, we learn from the speech and language therapists, we learn from the doctors. And that's kind of the beauty of neuropsychiatry, is that we're continually learning as well.
And I think you learn from each other, you know, like I always like to say I'm a bit of an amalgamation of every single OT I've ever met. So if you're meeting and you're getting yourself around those neuro OTs, you're definitely going to learn as much as you possibly can in that area.
So it's building those connections, isn't it? A lot of it. It's getting to know other people in the same kinds of services where you can share those ideas and learn from someone else's experience, isn't it? That's really important. And I guess, Alex, that's within the service line. I know that's something that you really encourage through those service line meetings, isn't it? About how people can interact and build that team identity.
Yeah, absolutely, because we all are learning from each other and we're all having different types of patients in our service. But if Georgia talks about a case that she's had, but we haven't had a type of patient like that in any of our services, we suddenly have that person. And then we think, oh, I remember Georgia talking about that case today and she did this and she did that. And then they know that they can go and talk to Georgia and say, oh, I've got a similar person that's come into my service. Can I just talk him through with you because he sounded really similar, and, you know, what was your approach? And I think that's really important to have those connections because they are complex patients, and we never expect that we're going to know every single answer and know exactly what we're going to do with that person walking into the building. And part of what makes it fun is that investigation part of, like, we do the assessments, we kind of unpeel, like,
The formulation of it all. Yeah.
what are we seeing? What are the challenges? How can I change and tweak that to be able to see a little bit more? And then being able to take that back to that group of OTs and say, so I've done these assessments. This is what I saw. This is what I'm thinking. This is going to be my rehab approach. What does everybody else think? And I think it's really important to have that network to be able to bounce those ideas off.
Absolutely. Is there anything else you'd like people to know? Things that maybe things that you think people might not be aware of, or preconceived ideas they might have? This is your opportunity to fly that flag for neuropsychiatry and get that out there. Is there anything else you'd like to share?
I guess that it is that culmination. I guess sometimes I think when I qualified, people pigeonholed themselves as you were either a physical health OT or you were a mental health OT. And I did the same thing. I was like, I'm not a mental health OT, I'm a physical health OT, and I'm going to work in brain injury. And I think as I've experienced more of neuro rehab and brain injury and worked with lots of different patients, you realise that actually I might think that I'm a physical health OT and I'm a neuro OT, but actually your brain's your brain. And whether that's a brain injury that you've had or whether you've got a mental health diagnosis, it is ultimately just your brain. So I think it's just being able to open your eyes to think that I'm not a mental health or I'm a physical health OT, that I'm just an occupational therapist and I look at occupation, and whether that's their difficulties of engaging in occupations because they've had a brain injury or because they've got schizophrenia, I'm ultimately finding out how I can enable them to engage in that occupation that's meaningful to them.
Absolutely. I think that's summed it up really nicely, Alex. Thank you so much, both of you, for coming in today. It's been really interesting, and hopefully people have learnt something new that are listening and are a little bit more interested in those services. People might want to go away and find out a little bit more, which would be great. So thank you for joining us.
Thank you.